In emergent head and neck presentations, a superficial symptom is often a trap. It forces you into a 50-50 diagnostic coin toss, where guessing wrong can be truly catastrophic. A muffled voice, a bloody nose, or a facial droop might look like straightforward, isolated issues. They create a false sense of security, tricking you into treating the surface while the underlying architecture collapses. Survival in these cases does not depend on symptom recognition. It depends on your ability to execute a rapid structural audit. You have to look past the presenting complaint and audit 3 specific anatomical domains: fascial planes, arterial pressure gradients, and fracture vectors. Mastering the tipping points within these 3 structures is the only reliable way to avoid the predictable and often fatal mistakes of resuscitation. Let's look at the first diagnostic dilemma. A patient presents with trismus and a muffled voice. The immediate clinical reflex is usually to diagnose a localized collection of pus in the throat. This reflex is built into standardized training. This question text shows how we are taught to identify a localized accumulation of pus and immediately proceed to needle aspiration. The tipping point between a simple localized issue and a systemic emergency comes down to one anatomical distinction: unilateral tonsillar deviation versus bilateral submandibular involvement. This cross-section shows the reality of a peritonsillar abscess. It is a localized, unilateral sphere of infection. As it expands, it pushes midline structures, like the uvula, sideways. Ludwig's angina behaves entirely differently. It is a rapidly spreading cellulitis spanning the submandibular, sublingual, and sublental spaces, usually originating from an infected mandibular tooth. Because the infection is bound by the rigid fascia of the neck and the mandible itself, the expanding brawny induration has only one path of least resistance. It forces the tongue directly upward and backward, entirely occluding the airway. This leads to a classic resuscitation error: taking a tachypnic patient with these signs and laying them flat on their back in a CT scanner. Gravity accelerates that posterior displacement of the tongue. The only structurally sound next step is immediate airway protection via an awake fiber optic intubation before the obstruction becomes irreversible. Our next domain is severe epistaxis. Here, the critical dividing line is distinguishing between anterior and posterior pathomechanics. This sagittal diagram highlights Kieselbach's plexus in the anterior nasal cavity. The vessels here are small and operate under low pressure, making them highly responsive to direct compression or chemical cautery. Further back, the architecture changes. The sphenopalatine artery supplies the posterior nasal cavity. This is a large, high-pressure vessel driven by arterial force. The clinical tipping point occurs when standard anterior packing fails. If you place a tight anterior pack and blood continues tracking down the posterior pharynx, you have a posterior bleed. Continuing to repack the anterior nose will achieve nothing. You must abandon serial repacking and shift immediately to definitive control, either through endoscopic sphenopalatine artery ligation or interventional radiology embolization. If you do place a temporizing posterior pack, a major error is discharging that patient home. A posterior pack places pressure directly on the trigeminal nerve branches, triggering the nasopulmonary reflex. This drastically increases vagal tone, causing nocturnal hypoventilation and profound bradycardia. Admission to the ICU or a telemetry unit is non-negotiable. Finally, we turn to blunt temporal bone trauma. In these injuries, the vector of the fracture line relative to the petrous ridge is the primary predictor of otic capsule integrity. This rendering maps the skull base. The glowing line demarcates the petrous ridge, the dense core of the temporal bone that houses the inner ear and the facial nerve. A longitudinal fracture runs parallel to this ridge. Because of its path, it typically bypasses the critical inner ear structures. In these fractures, any resulting cranial nerve 7 palsy is usually delayed. The nerve is intact, but secondary inflammatory edema gradually compresses it over days. A transverse fracture behaves differently. It slices perpendicular to the ridge, cutting directly through the otic capsule and severing the nerve pathway entirely. With a transverse fracture, facial paralysis is immediate. The nerve hasn't swollen, it has been physically transected. This brings us to a frequent mismanagement error: treating immediate onset facial paralysis conservatively with high-dose glucocorticoids. Immediate paralysis is a mechanical failure requiring urgent surgical decompression and repair. Delayed onset is a physiological reaction to edema, making it highly responsive to steroids. The timeline tells you the structure. Anatomy dictates urgency. You cannot let a superficial symptom mask a deeper structural collapse. Let's test this model. Consider a 28-year-old male post-motor vehicle collision presenting with right mastoid hematoma, immediate facial paralysis, and total hearing loss. This flowchart traces the lateral trauma to a transverse fracture, resulting in nerve transection. What is the most definitive next step in management? The answer is urgent surgical decompression. Administering steroids here ignores the structural reality of a severed nerve. Now consider a 44-year-old male with a mandibular tooth infection, drooling, and a muffled voice. He has symmetric, brawny submandibular induration, and his tongue is elevated. Our diagram links the dental infection directly to posterior tongue displacement. What is the absolute contraindicated next step for this patient's airway management? You do not lie this patient flat for a CT scan, and you do not use standard rapid sequence intubation. An awake fiber optic setup is mandatory to prevent gravity from sealing the airway shut. Elite clinical intuition isn't about memorizing a checklist of symptoms. It is built entirely on mastering first principles anatomy.